All right, now we're going to study the GI system, but before we get into the GI content, I want to talk to you a little bit about making room assignments. Making room assignments is a very important part of the NCLEX exam, so let's talk about that. And this is not on your handout, I'm just talking now, okay? Now, one thing that I want you to know is a basic rule for making room assignments, and here it is. Like illnesses can go together. Like illnesses can go together. Like illnesses can go together. All right? Now, what I'm going to do is take you through some examples now of how you would use that basic rule that we have. First of all, what if we had two patients that had the flu, and we could tell by reading the test question that they had the exact same type of flu? Would it be okay to put them in the same room together? Yes, because like illnesses can go together. Even though you and I know that when people have the flu, we would prefer to have them to have a private room, but a private room's not always available, and NCLEX is all about putting you in a bind. So I'm going to keep giving you examples where you're having to make a decision, all right? Now, let's say we had two patients that had TB. Tuberculosis. Could those two patients go together if they had the exact same type of tuberculosis? Ask your friend. If we know for a fact that they had the exact same type, because I know there are lots of different strains of tuberculosis out there, but if we know for without a doubt they had the exact same type, then yes, they could go in the room together, because like illnesses can go together. But what we always study in school is a private room, negative pressure. If the patient comes out into the hall, they have to wear a mask. The door has to be kept shut all the time, that sort of thing. Okay? But see, we may put them together if we have to. All right? Now then, here's another scenario. Let's pretend we have two patients that are HIV positive and they're in the hospital. Can they go in the same room together? Ask your friend. All right, let's think about this for a second. The first thing I want to ask you is this. What's the only reason that people that are HIV positive are ever put in the hospital? Is if they have an opportunistic infection, right? So these people are sick already, and both of these patients are immunosuppressed. So can they go in the room with each other? No, because you've got two patients that are immunosuppressed. One may have cytomegalovirus, the other may have pneumocystis. Both are immunosuppressed. Would you want to put them in the same room together? No. We always say that they have to have a private room. See, that's an example of having to be flexible with the knowledge that you've learned. What I told you was that like illnesses could go together, but I put you in a bind like NCLEX is going to do. Okay? Now then, I'm about to put you in another bind. Let's pretend we have somebody that is HIV positive in a semi-private room. So there's the patient in one bed and the other bed is empty. We've got 3 patients in the hospital that need a bed, so I'm going to force you to put somebody in the room with the HIV positive person. And now you're already saying in your mind, well, you just said they had to have a private room. I know, I'm putting you in a bind. This is what higher level thinking is all about. So I've got 3 patients for you. Who do you want to go in the room with the person that is HIV positive? The person with asthma, the person with bronchitis, or the person that is 8 hours post-appendectomy? Ask your friend. All right, what do you think? Asthma. Asthma is the answer because that is the only one that is not infectious, right? Yes. You see, bronchitis can be bacterial or viral. And then also, you would never want to put somebody with a fresh incision in the room with somebody that's HIV positive, okay? Those two things just don't go together. Now, let me give you another really good strategy to use when you are answering these types of questions, okay? When you're taking care of patients and you're making room assignments or you are giving report, follow this rule. Pretend the nurse you're giving report to or the nurse that's going to be picking up the patient load is not very bright. Now, I know that sounds silly, but you'll see what I'm talking about in just a second. Now, you see, if I were taking care, or you, if we were taking care of a patient that was HIV positive and the other patient in the room had a fresh incision, you and I know that we would use extreme hand washing and do everything that we could to prevent cross-contamination. But see, we can't be too sure about the person that's coming behind us if they would do the same thing. So another way that we protect the patient is to consider what's going to happen when you're not there. So we're assuming that the next nurse is not very bright. When you're giving report, don't assume that the next nurse understands everything you're talking about. When you're giving report, in a test question scenario we're talking about, you have to tell that person, that next nurse, the most important thing they need to know before you leave the hospital. In other words, I can't leave the hospital until I know for sure this next nurse knows to do X, whatever it is, okay? So those are some really good strategies that will help you in determining what you need to select as far as room assignments and that sort of thing. All right? Now, let me give you one more NCLEX scenario here. Let's pretend that we've got a patient, 18-month-old little girl who had the rotavirus, all right, in the hospital for the rotavirus, diarrhea, severely dehydrated, no tears, and has not wet a diaper in 5 hours. Well, that patient needs fluid, right? Yes. So they're in the hospital now, and the doctor has written an order for D5 1/2 normal saline with 20 of KCl at 20 cc's per hour per pump. All right? What would you do based on the data that I've just given you? I said they had the rotavirus, diarrhea, dehydrated, no tears, and haven't wet a diaper in 5 hours. And then the order was for D5 1/2 normal saline with 20 of KCl at 20 cc's per hour per pump. Based on this data, what should you be worried about? Ask your friend. Well, we've already agreed. We've already agreed that this patient needs fluid because they are so dehydrated, obviously. But what can they not handle right now? Potassium. They cannot handle the potassium in their infusion right now. How do I know that? Because they hadn't wet a diaper in 5 hours. It is a rule that you never give anybody IV potassium unless their kidneys are working well. Okay? Now, you may be saying, well, why did the doctor write the order? I don't know, but it's my place to question orders. Anytime you get an order on NCLEX, try to look for what's wrong with that order. We're supposed to question orders, and the doctors want us to use judgment when we're implementing their orders. That could kill that baby if you started potassium, because they don't have a way to excrete potassium, and then they would have a life-threatening arrhythmia. So here's what you do. You got to pick up the phone and call the doctor and say, look, I'm going to start the IV fluid and everything, but I'm not going to start any potassium on that baby until they start wetting some diapers. Okay? Okay, bye. That's what they want you to do, all right? Then when the baby starts wetting diapers, then you add the potassium to the infusion and continue to monitor their urine output, okay? All right, now let's go ahead and start looking at the GI system. And the first thing we're going to look at are some diagnostic tests. And the first test we're going to look at is an upper GI. It looks at the esophagus and stomach with dye. The patient's going to be NPO past midnight and no smoking. Now, I said no smoking for a couple of reasons. All right, you know, a lot of people think that when you're NPO that you can still smoke. That's a big no-no, because smoking is going to increase stomach secretions, so the patient may aspirate. It increases stomach secretions, so we don't want that. Another reason we do not want the patient to smoke is because it increases motility. And one of the things they look at with an upper GI is the motility of the stomach. So smoking would affect the test. So no smoking because it increases stomach secretions, and it also increases motility. We don't want to do anything that would alter the test. All right, now the next test we have is a barium enema, BE it is sometimes called. Clear liquids, laxatives, or enemas until clear. Well, that order scares me because can all patients tolerate laxatives or enemas until clear? No. Some people, when you are implementing that order, become very, very weak and debilitated because of all the fluid and electrolyte imbalances they're getting into. So you have to be careful with that order. They're losing lots of fluids and electrolytes, and the doctor wants us to watch the patient for that. Now, y'all, another point is this. For any lower GI test, many times they make them drink the big gallon jug of Go Lightly, don't they? Now, where do they get the name Go Lightly? I don't know, because they do not go lightly now, do they? No, they do not. All right, now let's think about that. They're going to have to drink a large volume of fluid. Usually they want them to drink about an 8-ounce glass every 10 minutes. So that's a lot of fluid, and I'm sure it doesn't taste wonderfully either. So you've got somebody who might get sick at their stomach. That's why the doctor many times will order Phenergan ahead of time in case they're starting to get nauseated. Something that will help your patient is to let it get really, really cold. Go Lightly. The colder it is, the better they can tolerate it. And don't let them drink it with a straw, because if they drink it with a straw, they're going to swallow more air, which causes more GI upset. It's kind of the same principle as if you have an oncology patient, for instance, who wants a Coke. You let it sit there a minute open, let some of the fizz go out, let some of the carbonation go out so they won't be swallowing so much air when they drink that drink. All right. Now, the last thing on your handout under barium enema says, post-procedure, make sure the patient has a bowel movement. They've got to have a bowel movement because the barium has got to come out, and that patient may have to have another enema for that barium to help the barium come out. There have been times when they have to go in there and scope the patient to remove the barium, and then there are cases that I've seen where they had to go in and surgically remove the barium, because if you do not remove it, it will stay in the intestine and get hard as concrete. So we've got to make sure they have a bowel movement. Now, gastroscopy. As you know, with the gastroscopy, that's a tube going into the oropharynx, isn't it? Yes, it's a tube going in through the mouth. Now, there are lots of procedures out there where they will put a scope through your oropharynx. So, for this procedure, remember what we learned here is applicable for any procedure where they're going in through the oropharynx, like an EGD or an endoscopy. We're going to go over the general guidelines that we go by, all right? NPO pre, of course, they're going to be sedated, I hope, right? And then NPO until what returns? The gag reflex. Now, the gag reflex. When they come back without a gag reflex, that's okay. That's expected, because normally they spray something in the back of the throat to numb up the back of the throat, so when they pass the tube, the patient won't gag as much. So it's okay for them not to have a gag reflex. You just make sure that they stay NPO until the gag reflex returns, because if you give them something to drink and they do not have a gag reflex, could they aspirate? Yes, they can aspirate. Now, the signs of perforation. It says on your handout to watch for perforation. Well, how do you know somebody's perforated? All right, you look for any unusual discomfort or pain. Unusual discomfort or pain. Unusual discomfort or pain. Now, let me tell you a basic concept here. When you send a patient for a procedure, you need to kind of get an idea of what they were like and what their complaints were before they ever went. Because if they come back complaining of anything new and different, you and I have to assume the worst and assume that there's a problem going on. So if they didn't have pain or unusual discomfort before they left, they shouldn't be having it now. Now, the next thing we have on your handout is a liver biopsy. There are tons of questions I could ask you about a liver biopsy. Before we get into the notes, let's talk about the liver for a second. First of all, do you agree that your liver is very important for detoxifying your body? Yes, your liver is very important for detoxifying your body. That's why when your liver is not working, you aren't getting rid of toxins like you should, and you feel so tired all the time. Also, do you agree that another important function of the liver is to help your blood to clot? Yes, another important function of the liver is to help your blood to clot. If your liver is messed up, the number one thing you're supposed to be worried about is hemorrhage. But anytime you get a liver question, I always think hemorrhage first. I don't care if it's hepatitis or whatever. If it's a liver thing, we're worried about hemorrhage. When you have a liver problem, what has to be done with medication doses? Decrease the dose. The medication doses have to be decreased, and we hope the doctor will do that for us, but sometimes they forget, so we have to be sure and check. You know, it's like this. If you gave a routine dose of Demerol to somebody with liver disease, like 75 milligrams, it's the same thing as giving them a double dose, because can they metabolize it like they should? No. So it could affect their respiratory rate. And we're going to talk more about that in just a little bit. Now, there is another drug out there in the world that you should never, ever, ever give to liver people. What is it? Tylenol. Never give Tylenol to liver people. They will get toxic on it because they can't break it down. It attacks your liver. And if your liver's being attacked, what's going to happen? The patient's going to bleed. That's what's going to happen. What's the antidote for Tylenol overdose? Mucomist. Mucomist is the antidote for Tylenol overdose. It comes in a very small vial, and it's a clear solution. You've got to mix it in a carbonated drink, and it smells really, really, really bad. All right, now liver biopsy. They are about to take a needle and puncture into a sick liver. So what are you really concerned about now? Once again, hemorrhage. Okay, so here we go. Clotting studies PT and PTT is what I'm talking about here. Get those vital signs, because what am I scared of? Hemorrhage. You got to have your baseline vital signs. Now, how do you position this patient? Ask your friend how we would position a patient for a liver biopsy. Okay. In school, we always study post-procedure positioning with the liver biopsy, all right? But now I want you to tell me how to position the patient during the procedure. So here's what I want you to write down. Supine with right arm behind the head. Supine with right arm behind the head. Supine with right arm out behind the head. Now what's going to happen is the doctor's going to come in and he's going to raise the bed to working height. He's going to take the pillow out from behind the patient's head, and then he's going to take his right arm and put it behind his head just to get it out of the way. Now the reason we want the patient flat is that we want them stable. And when I say stable here, I mean not wobbly, all right? You want a stable patient. You don't want them to be wobbling around. And the doctor's going to tell the patient to exhale and hold to get the diaphragm out of the way, because we do not want to puncture into the diaphragm, do we? No, we do not want to puncture into the diaphragm. Now, I've seen test questions out there in the world where they'll say something like, the patient must be able to hold their breath for 30 seconds. How long do you think it takes for a doctor, once they have found the appropriate intercostal space, to take a needle and stab into the liver? A couple of seconds. So the patient does not have to be able to hold their breath for an extended period of time. So even if they're on the ventilator, this procedure can still be done. Now then, post-procedure, lie on what side? Right side to hold pressure. Right side to hold pressure. Control bleeding. And that's a good thing. You can even take a blanket or a towel and roll it up and stuff it under the patient at the liver area to hold even more pressure. That would be appropriate too. And I want you to keep on checking those vital signs, because even though the procedure is over, what can my patient still do? Hemorrhage. Now tell the person sitting next to you what is going to happen to the blood pressure and pulse if somebody should begin to hemorrhage. All right, the blood pressure is going to go down and the pulse is going to go up. Good. All right. Now let's look at paracentesis. We always study paracentesis in the GI system because do you agree that with many liver problems that people have ascites? Yes. So a paracentesis may be indicated. Now don't get me wrong. There are other conditions out there in the world like cancer or whatever where fluid can accumulate in the abdomen too. But most typically we see the use of a paracentesis in the GI system. All right. Liver people tend to have ascites. All right. With paracentesis, it is removal of fluid from the peritoneal cavity. You already know that. Now, before we go on, I want you to ask your friend how ascites can affect the vascular space. How does ascites affect the vascular space? Well, we said earlier in the class that if you have a lot of fluid accumulating in your abdomen, that this fluid is just not magically appearing. It has to come from somewhere. That fluid that is building up in my peritoneum is actually coming from my vascular space. So the bigger I get here, my vascular volume is coming down. So see, ascites can make me hypovolemic, can it? Yes, ascites can make me hypovolemic. So you might better be checking my blood pressure, to make sure I'm not already a little bit shocky or hypovolemic. You see, when you look at that patient with a lot of ascites, they look like somebody that's in a fluid volume excess, but is the fluid in the right place? No, the fluid is not in the right place. It's in the wrong place. That's why we call it third spacing. All right, we're going to have the patient void. This is going to be a low puncture, okay? So I want them to void ahead of time because I want their bladder to be teeny tiny. I don't want to puncture into the bladder, all right? Now, tell your friend what position you put the patient in for this procedure. Okay. Any position that is sitting up. Any position that is sitting up. Sitting up. And the reason for that is this. If they were lying down, all the fluid would just be everywhere. It would be hard to collect that fluid. So you sit them up, like elevate the head of the bed or sit them up in a chair, something like that, so all the fluid will settle down. So they can do a low puncture to remove the fluid. Now, when you do that, all the fluid goes down and the intestines will actually float up and out of the way because we don't want to puncture into the intestines. Because now you've got somebody leaking bowel contents into the peritoneum and they're about to have to go to emergency surgery because they're going to get septic, aren't they? Yes. Every once in a while, you will run across a patient who, for comfort reasons, will meet their doctor at the ER. Maybe they've got a tumor that is secreting fluid into the abdomen, and it's very uncomfortable for them because the more fluid you get in here, it presses up on your diaphragm, so now the patient has trouble breathing. So as a comfort measure, they meet their doctor in the ER from time to time to drain off that excess fluid so they can breathe better. Anytime you've got somebody with ascites, think breathing troubles. Ascites, breathing troubles. They can't lie flat. They cannot stand that. They feel like they're suffocating. Now, it also says on your handout to keep on checking the vital signs. Should I have gotten some baseline vital signs to start with? Yes, I should have gotten some baseline vital signs. But why am I worried about vital signs here? Because we're pulling fluid off of somebody. And we know now that anytime you're pulling fluid off of somebody, they could go into shock, couldn't they? Yes. So that's why we're keeping on checking the vital signs, because we're worried about shock. Now then, let's move on and talk about pancreatitis. Pancreatitis. The pancreas has two separate functions, endocrine, exocrine. Now, the endocrine function would be the production of insulin. All right, the production of insulin, and exocrine would be your digestive enzymes. All right, that's where we're going to focus today. There are two types of pancreatitis, acute and chronic, and as you can see on your handout, the number one cause for acute and chronic is going to be alcohol. Now, do you remember when we were talking about the alcoholic, we said that alcohol destroys the GI tract? Yes, every part of your GI tract, and you'll see what I'm talking about in just a second. Now, when people are in the hospital and they've got pancreatitis, many times people automatically assume, well, they must be an alcoholic. That is not always true, because other things can cause me to get pancreatitis as well. So I'm going to draw you a picture of a little pancreas here and just show you what's going on, okay? Believe it or not, that's a pancreas. And through the center of your pancreas, you have a duct. And as you know, living out here in the pancreas, we have enzymes. And as long as these enzymes are inside my pancreas, they are inactive, aren't they? Because what do pancreatic enzymes do? Digest. And do you want to digest your pancreas? No, because that would hurt, now wouldn't it? Right. So they are made to stay inactive as long as they are inside the pancreas. But when you eat or even smell food, those enzymes move into the pancreatic duct and they go over here till they finally get to the small intestine. Now, when they get to the small intestine, they activate. That's okay for them to activate in the small intestine. Okay? Now, if you are an alcoholic, I've already said that your GI tract is going to be destroyed. And your pancreas is part of your GI tract. So what happens is you get all this scar tissue in here. Scar tissue in your pancreas is now lumpy and bumpy. But all this scar tissue could make an occlusion right here. And now the enzymes cannot get out. They are blocked in from the scar tissue. Also, if I have a patient with gallbladder disease, they may be fine today. They may not even know they have gallstones until one of them drops and lands right there. Well, do we have an occlusion now? Yeah. The enzymes can't get out, whether it's from alcohol or a gallstone. The enzymes cannot get out. They get tired of waiting to activate. So what do they just go ahead and do? Activate inside the pancreas. That's why we call pancreatitis autodigestion of the pancreas, because it is eating itself. The pancreas is eating itself. Autodigestion of the pancreas. Now, as you can see on your handout, the first sign is going to be pain. Now remember, with pancreatitis, there are degrees of it, just like with any other disease. You may have a small case of it where you have a patient who's up on the floor and they have an NG tube hooked to suction their NPO and they're uncomfortable. And then you can have somebody who has such a horrible case of pancreatitis where it's really digesting itself a lot and toxins are being released into the body and they go into multi-system breakdown, because when you get those toxins being released into your body, that's when people start having arrhythmias. They stop breathing, their kidneys shut down. People can die within 24 hours if this is not diagnosed quickly. It's very serious. Now let's look at our signs and symptoms. Pain. Now, does the pain increase or decrease with eating? It's going to increase, because when you eat, you make more what? Enzymes. You're going to make more enzymes when you eat. Abdominal distension and ascites can occur, because the circulating pancreatic enzymes will damage the capillaries, causing ascites. You may feel an abdominal mass. That's just your swollen pancreas. That is your swollen pancreas. The patient may have a rigid board-like abdomen. Well, let's understand that. They may have a rigid board-like abdomen because they're guarding, because they hurt. All right? But you know, anytime I see the words rigid board-like abdomen, it makes me wonder, are they bleeding inside? That phrase, rigid board-like abdomen, many times means that they're bleeding internally. This is when you may see a doctor do something like a peritoneal tap or a peritoneal lavage where they'll run a bag of saline in and then lower it to the floor. And if it comes out pink tinged, we know they're hemorrhaging internally. You may see that done in the ER, like after an MVA or something like that, where they're trying to see if somebody is hemorrhaging inside. Bruising can occur. And I bet your teacher told you that they have bruising in weird places. Okay, well, if you're bleeding inside, the blood is going to settle in different places, all right? Now, umbilical bruising is one place where you can see the bruising. A ring around the umbilical area called Cullen's sign, or you may see a bruise over the flank area called Gray-Turner's sign, okay? Now, not everybody gets that type of bruising. It just depends on if they're bleeding inside or not. Think about it. If you're lying flat of your back, the blood's going to settle back. So that's why you would see bruising over the flank area. I really don't understand why they get the umbilical bruising, okay? But that's very specific for pancreatitis. Also, fever can occur because do you think they have inflammation? Yes, they're inflamed. Inflammation. Nausea, vomiting. Now, jaundice tells you what's gotten into it. The liver is in it now. The liver has gotten involved. Now, here's a basic rule. Anytime one part of your GI tract gets sick, expect any other part of the GI tract to get sick too. For instance, if my gallbladder gets sick, can it make my pancreas sick? Yes. If my pancreas gets sick, can it affect my liver? Yes. When my liver is sick, can it affect my esophagus? Yes. Bleeding esophageal varices. All right. So you get the whole GI tract involved at some point in time. Now, hypotension can occur for two reasons. See if you and your friend can figure out what the two reasons are. I know you can. Well, one reason may be because they're bleeding, right? Yeah, if you're bleeding, that's going to make your blood pressure drop. And the other reason is because of ascites. Ascites will make you hypovolemic as well. So bleeding and ascites. Bleeding and ascites. Also, the serum lipase and amylase are going to go up. These are your digestive enzymes. Now, y'all, you are not supposed to have digestive enzymes in your blood. Now, are you? No, they're supposed to be in your intestines. Well, what happens is they get tired of sitting in the pancreas, so your blood starts resorbing them. That's why those blood levels start to go up. So your lipase and amylase are going to go up. White count is going to go up. White count's going up. We have inflammation. We might even have some infection in there. Blood sugar. What do you think about the blood sugar? Up. The blood sugar's going to go up because my pancreas is messed up. My pancreas is messed up. And could I be a diabetic forever now? Yes. I could have so much damage to my pancreas that I'm going to be a diabetic forever. My SGOT and SGPT, my liver enzymes, are going to go up. You guys know ALT and AST. The names have changed over time. SGOT is your AST. SGPT is your ALT. Now, let's just talk liver enzymes in general. I've never seen a time when liver enzymes go down. I'm sure there's a time, but as a rule, they usually go up if your liver is sick, okay? They're either normal or up. PT and PTT, do you think these will get shorter or longer? Ask your friend. Well, when your liver is messed up, we've already said you're at risk for bleeding. So your PT and PTT are going to be prolonged. Your PT and PTT are going to be prolonged. Now, what does that mean? It means it's taking longer for your blood to form a clot. It's taking longer for your blood to form a clot. Now, so if your PT and PTT are prolonged, think hemorrhage. If your PT and PTT are short, the patient's going to get a clot, aren't they? Yes. Serum bilirubin, what do you think? Is it going to go up or down? It's going to go up. It's a liver thing again. Also, hemoglobin and hematocrit. Now, here's the deal. It can either go up or down. Now, let's get something straight. I don't mean at the same time, depending on different conditions. Tell your friend what could make the H&H, the hemoglobin and hematocrit, go up, and what could make the H&H go down. Okay, if you're bleeding, your H&H is going to go down, bleeding down. But if you are dehydrated, the H&H is going to go up because you're so concentrated. The blood is very concentrated, so the hemoglobin and hematocrit would go up in that instance. Okay, let's look at treatment now. Well, first of all, we've got to control the pain, all right? We decrease gastric secretions by keeping the patient in PO. They need an NG tube to suction and bed rest because bed rest decreases stomach secretions. Bed rest decreases stomach secretions. Now, when you're thinking about the pancreatitis person, remember to keep their stomach empty and dry. Keep their stomach empty and dry. That is very important. Keep their stomach empty and dry. And you know, that's why they've got the NG tube to suction, to keep it dry, right? To keep it empty. And we're going to give them some medicine in a little bit to help keep it dry as well. Here's the deal. If anything gets into their stomach, what is that pancreas going to think it needs to do? Make enzymes. And that's what's making them hurt. We don't want them to make enzymes. We want the pancreas and the entire GI tract to just chill out for a little while. Now, drugs. Demerol is the drug of choice for NCLEX, okay? No morphine or codeine on this test. Now, past research says that morphine and codeine causes more spasm of the sphincter of Oddi, which is the muscle surrounding the exit of the bile duct and the pancreatic duct into the duodenum. New research finds this to be untrue, all right? Now, in the real world, I'm going to tell you, I have taken care of people with acute pancreatitis who are getting continuous infusions of morphine. But would that be right on NCLEX? No. For this test, y'all, we have to learn information, a safe way for the test. And then when you get out there in the real world, then you expand and do what we go more along with what our doctors and what the latest research says then, all right? I'm giving you basic, good standards to go by that are safe on this test. Now, due to the increased concerns with adverse reactions with Demerol, the physician may use fentanyl patches, PCA narcotics, Dilaudid, and Toradol may also be used for pain relief, all right? Now, steroids are going to do what? What are steroids going to do? Decrease inflammation. Decrease inflammation. Now, if I stay on steroids long enough, what other disease am I going to get? All right, I heard you say diabetes. Diabetes, you're right, because steroids make your blood sugar go up. Steroids make your blood sugar go up, but also Cushing syndrome. Cushing syndrome. Remember, Cushing syndrome is when you have too many steroids in the body. Too many steroids. All right. Now, what do anticholinergic drugs do? They're going to dry you up. Dry you up. I said we want to keep the stomach empty and dry. And so that medication is going to help us with that. The patient will be getting IV meds to decrease stomach acid, like Protonix, that's a proton pump inhibitor. Zantac, Pepcid, and antacids can also be given because we're just trying to decrease acid. Decrease acid. We want to maintain fluid and electrolyte balance, and we've all learned how to do that if you've listened to us lecture on fluids and electrolytes. Maintain nutritional status. Now, when they start to eat again, we're going to ease them back into a diet very slowly. Now, for a period of time, depending on how sick they are, they may have to be on TPN, total parenteral nutrition. Their GI tract may be so sick that we don't want anything going through it, so we're feeding them intravenously, you see. But when we do start letting them take things by mouth, we'll start with clear liquids, see how they do for a day or so, and then just keep on adding just to make sure they can tolerate it. And also it says on your handout, insulin. Now tell your friend why this patient, there's 2 reasons why your patient may need insulin. One reason our patient may need insulin is because the pancreas is sick. Yeah, so it's not making adequate insulin like it used to, all right? But also because your patient is on what type of drug? Steroids. And steroids make your blood sugar go up. Steroids make your blood sugar go up. Good. Now then, moving on to cirrhosis. Cirrhosis. This is when liver cells are destroyed and are replaced with connective tissue and scar tissue. This alters the circulation within the liver, so the blood pressure in the liver goes up. And when you have high blood pressure in your liver, this is known as portal hypertension. Portal hypertension. Portal hypertension. You are not supposed to have high blood pressure in your liver. Now, are you? No, you're not supposed to have high blood pressure in your liver. But see, all that alcohol has destroyed your liver because that's a GI tract organ and the blood pressure's going up. Now, we're about to talk about a lot of signs and symptoms here, and the majority of these signs and symptoms are applicable for any liver disease in the whole wide world. Okay, so this is going to be your liver lecture. Signs and symptoms, firm nodular liver. All right, first of all, when you are doing an abdominal assessment, are you supposed to be able to feel the liver? Not in the normal patient. You may think you're feeling it, but most of the time you're not. There won't be any doubt about this liver enlargement. This liver can be so big that it can cover the entire abdomen. I mean, think about it. We've all watched those shows where they've done liver transplants, and when they remove the diseased liver, do they hold it with one hand? No, they hold it with 2, don't they, and carry it because it's so big and so diseased, okay? It can get really, really, really large. Abdominal pain is another sign, all right? Well, here's the deal with that. Your liver has a capsule around it. Your pancreas has the same thing, okay? But your liver has a capsule around it, and that capsule is filled with nerves. And when your liver enlarges, it stretches the capsule and stretches the nerves, and it hurts. Try to do an abdominal assessment on an alcoholic patient sometime, and they'll guard. They're very tender there because that capsule is so stretched out. All right, another thing I want to talk about here that's not on your handout, and you don't have to write this down because we'll talk about it in the OB section. But think about the person with preeclampsia or pregnancy-induced hypertension. They're swelling, aren't they? Yeah, their face is swelling, their fingers are swelling. Well, if you're swelling on the outside, you're swelling on the inside. So could my liver start to swell with preeclampsia? Yeah. Well, anytime you have the liver that's swelling, the patient may start complaining of epigastric pain. Now, here's just a rule. If you ever see a pregnant lady that starts complaining of epigastric pain, I didn't say discomfort and indigestion. I said pain. You assume the worst, especially if they've got PIH, because that could be a sign that their blood pressure is getting really, 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 really high, and they're about to have a seizure. And we'll talk more about that later. Now let's go back to our signs and symptoms. Chronic dyspepsia, that's just GI upset. That's all that is. GI upset. Liver people, alcoholics, they always have a GI upset, all right? They always have a bowel complaint. Their bowels are never right. Ascites can occur too. and you'll see why in just a second, as well as splenomegaly can occur. Now, anytime you see someone where their spleen has enlarged, you need to remember that their immune system has kicked in. The immune system has kicked in with splenomegaly. Because your spleen is an immune system organ, isn't it? Yes, it's your filter is what it is. It's your filter. Well, if your liver's messed up, it's not filtering like it used to. So what's happening here is your spleen is trying to compensate and help. Now here's something, a biggie that we've got to talk about. Decreased serum albumin. Decreased serum albumin. Well, first of all, you and I eat albumin, don't we? Yeah, because we eat protein. Albumin is a type of protein. Well, we're all well nourished, aren't we? Yes, so we have a good serum albumin level or serum protein level. But if you've got somebody, let's say, who's an alcoholic and they're not well nourished, or maybe a cancer patient who isn't able to eat the amount of protein they need to, their serum albumin level can start to do what? Drop. Think about an elderly person in the nursing home or somebody at home that the family's trying to take care of and they're not eating like they should. Could their protein levels drop? Their albumin levels, yes, they can drop. But another point is this. Your liver makes albumin. Your liver makes or synthesizes albumin. And if your liver is sick, it's not able to make albumin anymore. All right? So again, your serum albumin level just dropped. Now, tell the person sitting next to you how albumin works or how albumin affects the vascular space. We said in fluids and electrolytes or burns that albumin holds on to fluid in the vascular space, doesn't it? Yes, albumin holds on to fluid in the vascular space. I'm going somewhere with this, I promise. If your serum albumin level is low, can you hold on to fluid in the vascular space? No. So where is all the fluid going to go? Out into the tissue, or maybe into the peritoneum. That decreased serum albumin level could be one of the major reasons liver people have ascites. One of the major reasons that people have ascites. Anytime you have somebody in the hospital who just for whatever reason, who knows why, unexplained swelling. They develop unexplained swelling. Maybe their forearm, maybe the inside of their left thigh, and there's no redness, no heat, or anything like that. Unexplained swelling. Ask the doctor if you can check a serum albumin level. Many times that's what the problem is. And remember, when you're taking care of somebody in the hospital, you deal with as many problems as you can because you might be their last shot at getting help for whatever the problem is, okay? All right, moving on now. Increased SGOT and SGPT again. That's just a liver thing. All right, that's the same thing as your AST and your ALT. That's on your handout. Just your liver enzymes are going to be elevated. Anemia can occur because my liver is sick, so can I bleed? Yes, and if you're bleeding, you're going to become anemic. And this can progress to hepatic encephalopathy and coma. Because anytime your liver is sick, what chemical can build up in the blood? Ammonia. Ammonia can build up in the blood. Anytime you've got a liver problem, think ammonia. Liver problems, think ammonia. And ammonia acts like a sedative. Ammonia acts like a sedative. So that's why they might go into a coma, hepatic encephalopathy, because of all this sedative and ammonia that's building up in their body. What if I get something like Reye's syndrome? Reye's syndrome that we see in pediatric patients. Well, that's a liver thing. All right? That's a liver thing. So could that patient go into a hepatic coma? Yes. What if you've got somebody who needs a liver transplant? What's going to build up in their blood? Ammonia. So they may end up going into a hepatic coma. What if I OD on Tylenol? Yeah, my liver's not going to be working right. So that person can go into a hepatic coma as well. Now, treatment for cirrhosis. Antacids, vitamins, diuretics. No more alcohol, please. I think we've had enough. I know, daily weights, because anytime you've got somebody with ascites, you've got a fluid problem, don't you? Yes, if you have ascites, you've got a fluid problem. Now, there's the rest again. Why did I tell you liver people needed rest? Because what do they have building up in their body? Toxins. They have toxins building up in their body. Now, put you a big star by prevent bleeding. That's very important because their liver's messed up. Would it be appropriate to give this person an IM injection? No, because they're going to bleed. They're going to have a big hematoma in the muscle. Would it be appropriate to give this person some aspirin? No, because that's going to make them bleed. Measure abdominal girth. You know why on that, because we have ascites, right? And monitor the jaundice. Now, where is the first place that we may see jaundice? The sclera. That's right. Now, tell me something. By the time the jaundice gets out here on my skin, what is the patient going to start doing? Itching, itching, itching. That's when you need to clip their fingernails short and maybe put some mittens or socks over their hands and do really, really, really good skin care. Really good skin care. Now, I also want you to put a big star by two more things. One thing is avoid narcotics. Narcotics and liver people don't work well together, okay? See, the liver can't metabolize the drug. They can't break it down if the liver's sick. So I told you earlier, when you're giving meds to liver people, it's like giving them a double dose. So we have to watch the doses of the medicines very closely, especially narcotics, right? Yes, don't ever give a narcotic to a liver person on NCLEX. It'll be wrong. Now, put you another star by decreased protein. This is a biggie too. If liver people eat too much protein, that's going to make their serum ammonia level go up. Yes, protein in the diet makes your ammonia level go up. So that's why we're limiting that. And anytime your ammonia level's going up, that's going to make your LOC go down. That's right. LOC is going to go down because ammonia acts like a what? Sedative. Ammonia acts like a sedative. Of course, they're going to need a low sodium diet. Well, they have ascites. That's going to help with that ascites fluid.